Hey everyone, let's jump right into this explainer and decode a pretty fascinating medical mystery. We're looking at how a single microscopic molecular tool helps us diagnose hidden diseases deep inside our bones. So whether you're actively studying clinical medicine or, you just want to understand how your own skeleton actually heals, alkaline phosphatase, or ALP, well, it's basically the ultimate biochemical detective. To truly grasp how this works, here's our agenda for today. We'll cover the foundation of ALP, how bones are built, normal demographics and healing, what happens when bone building fails, the grand diagnostic matrix, and finally, clinical best practices. All right, let's kick things off with Section 1, the foundation of ALP. Now, instead of getting totally lost in textbook jargon, I want you to just think of ALP as a highly specialized biological tool. Specifically, it's a hydrolase enzyme, and it's powered by a zinc core. And, well, exactly like its name suggests, it operates best in a highly alkaline environment, really thriving at an optimum pH of right around 9 to 10. So what does this actually look like in action? Well, ALP acts as a chemical catalyst. You can picture it kind of like a tiny pair of molecular scissors. It steps in and literally clips a phosphate group off of larger molecules, like a phosphate ester. And the result? It releases an alcohol, and this is absolutely crucial for our bones, free inorganic phosphate. Definitely keep that free phosphate in mind, because it's the foundational building block for everything we're about to talk about. But, okay, here's where it gets just a little bit tricky. You see, ALP isn't just one single thing located in one specific place. It's actually produced in a few different areas across the human body, like the liver, the intestines, and even the placenta during pregnancy. For our explainer today, though, our primary focus is strictly on bone ALP, or BALP. This specific isoenzyme is produced exclusively by your bone-building cells, so it gives us a highly targeted, super-specific window right into your skeletal health. Which leads us nicely into Section 2, how bones are built. You can really think of bone remodeling as this constant, ongoing battle between two main types of cells. On one side, you have the osteoblasts. These are your builders. On the flip side, we have the osteoclasts, and those are the destroyers. To maintain a healthy, solid skeleton, these two competing forces absolutely have to stay in perfect balance. Basically, old bone gets destroyed and new bone is immediately formed to replace it. So here is the absolutely crucial point, what we call the golden rule of clinical enzymology. Bone ALP is an exclusive marker of bone formation. Let me repeat that. It is not a marker of bone destruction. Whenever we see high levels of bone ALP in a patient's blood, it tells us definitively that the osteoblast builders are hyperactive. They are in there working overtime, totally regardless of what the destroyers happen to be doing. Let's trace the bone mineralization pathway to see exactly how this builds step by step. First up, the osteoblaster builders lay down this soft matrix called osteoid. Then they deploy our trusty tool, the ALP enzyme. The ALP hydrolyzes compounds to release those free phosphate ions we talked about earlier. Next, that free phosphate actively combines with calcium. And finally, they form these rigid hydroxyapatite crystals, locking together into the solid, mineralized bone that literally gives our body structure. Moving right along to Section 3, normal demographics and healing. Now, when you start comparing different demographics, you'll notice an adult's baseline sits pretty quietly between 40 and 130 units per liter. But, and this is important, it is completely normal for children and especially adolescents to have massively spiked ALP levels. Why is that? Well, because their skeletons are actively growing. Those crazy puberty growth spurts require incredibly intense osteoblast activity, so their baseline ALP is naturally going to look way higher than a typical adult's. We also see a very predictable timeline when an adult breaks a bone. The moment a fracture happens, it immediately triggers the builders to start repairing. ALP actually serves as a sort of biological clock for this whole process. It hits its absolute peak exactly 2 to 4 weeks post-fracture, right as the new bone callus is forming. Then, as the bone finishes healing up and solidifies, the ALP levels slowly resolve right back down to their normal baseline. Okay, let's look at Section 4, when bone building fails. So this brings up a genuinely fascinating question. If ALP is our marker for bone building, why on earth does it rise so dramatically during severe bone diseases? It kind of seems like a paradox, right? Shouldn't sick bones have less building going on? Actually, no. Elevated ALP simply indicates that those osteoblast builders are intensely stimulated. They're desperately trying to repair a skeletal defect.
basically dumping ALP into the bloodstream in a total panic response. A really perfect example of this is what we see in mineralization defects, like rickets in children or osteomalacia in adults. In both of these conditions, the builders are working overtime, which of course gives us an extremely high ALP on a lab test. But here's the catch. The patient lacks the crucial vitamin D, calcium, or phosphate needed to actually solidify the bone. So the builders just keep pouring out ALP trying to fix it, but the bone remains dangerously soft, leading to structural deformities like Bolex.
Now, another truly fascinating example is Paget's disease of bone. In this condition, the osteoclast destroyers basically go completely rogue. They start chronically eating away at the bone tissue. And in response, the osteoblast builders panic. They frantically try to fill in the gaps, which leads to this chaotic, totally disorganized overcompensation. Because the builders are in absolute overdrive, Paget's disease actually produces the highest ALP levels of any metabolic bone disorder we currently know of. This brings us to Section 5, the Grand Diagnostic Matrix. But, hey, before we look at the diagnostic matrix, you need to remember this core warning. A perfectly normal ALP level does not necessarily mean a patient's bones are fine. Diseases that don't trigger those massive osteoblast cascades will actually show completely normal ALP levels. The classic textbook example here is osteoporosis. Unless there is an active fracture, an osteoporosis patient will usually have totally normal ALP, even as their bones are becoming dangerously brittle. Okay, so by measuring ALP alongside calcium and phosphate levels, we can create this grand diagnostic matrix. This is literally how we crack the code. Think about it. If ALP is extremely high, but calcium and phosphate are low, we're likely looking at rickets or osteomalacia. But what if we see the highest possible ALP spikes while calcium and phosphate somehow remain perfectly normal? Well, that points squarely to the chaotic remodeling of Paget disease. It's like a brilliant biochemical fingerprint for each specific condition. And finally, let's wrap things up with Section 6, Clinical Best Practices. As we noted a bit earlier, because ALP can also come from places like the liver, context is absolutely key here. To practice safely, clinicians must always interpret elevated ALP results alongside other liver-specific tests, like GGT. Only by completely ruling out the liver can we definitively prove that this molecular signal is actually coming from a distressed skeleton. Maximizing that specificity is just critical. Ultimately, measuring this specific enzyme provides massive clinical utility for us. It allows us to accurately diagnose complex metabolic diseases, visually track that 2 to 4 week fracture healing timeline we discussed, and even assess the severity of Paget's disease. Honestly, it even helps oncologists monitor the burden of metastatic bone tumors, like those originating from breast or prostate cancer, simply by watching the ALP levels rise and fall in response to their therapy. So understanding alkaline phosphatase isn't just about memorizing biochemical pathways. It's really about learning to listen to the chemical language of our own cells. And it leaves us with a pretty fascinating question to ponder. As we get better and better at mapping specific biomarkers like bone ALP, how will our ability to intercept these silent diseases before a bone even fractures change the entire future of predictive, personalized medicine? Thanks so much for joining me on this explainer today. And as always, keep questioning what's beneath the surface.